Okay, guys, this is a 60-year-old lady presenting with right iliac fossa pain. Ultrasound done showed some inflammation in the right iliac fossa. CT with IV venous contrast was done to identify what could be the possible etiology. Let's look at the axial CT sections as we go from up to down. Let's head down closer towards the area of concern, which is the right iliac fossa. So as you can see, as I start coming down here, you can see that there is beginning of dirtying of the fat, okay, in the mesentery. So the fat is becoming more hyperdense, unlike the normal fat signal, which is dark in the CT scan. And when I come to this region over here, there appears to be an area of inflammation, okay? So we need to identify what's going on over here. Okay, so identify from where it is and what's happening. So let's look at the colon. So this is the right-sided colon. So this would be the ascending colon. So as I track it downwards, as I keep coming down, down, down towards the proximal ascending colon and the cecum, let's try to identify if you can see the ileocecal junction. So look at this area. There appears to be some fat intruding into the cecum. So that appears to be possible site of the ileocecal junction. So this appears to be the terminal ileum, okay, and then it is invaginating into the ileocecal valve and towards the cecum and ascending colon. All right. So let's see what's happening here. Now see here, okay. So this is the appendix, okay. So ileocecal junction, appendix, ballooned, dilated. Let's trace the appendix. What's happening? There appears to be some hyperdense content within, possible fecolith, appendicolith, and this appendix all of a sudden is having thinned out walls which are interrupted in enhancement. There is a large air focus identified here which is ballooned up into a fluid collection which is showing an air fluid level. Some adjacent bowel loops are also inflamed in and around it, okay. uh, so so it is a case of an inflamed appendix that has possibly ruptured, and there is an appendiceal phlegmon or an abscess, okay, in this area. Now, how did we identify it? So if you see here, I can identify the tip of the appendix. So this is the tip of the appendix. Much of the body of the appendix, the portions of the appendix are shrouded by fluid. So a portion of the appendix has expanded and ballooned up and possibly ruptured, and it is contained, and there is localized inflammation, and there is reactive inflammation of the adjacent small bowel loops in the region, okay. So you can see all these small hyperdense round lymph nodes, which are the ileocolic lymph nodes, which are again reactive to the inflammation that is happening in the right iliac fossa around the appendix. So this is a case of a ruptured appendix with contained perforation, abscess formation or phlegmon, as you would like to describe it, with reactive inflammatory changes in the adjacent small bowel loops. The reactive inflammation is demonstrated by the hyper enhancement of the wall that is adjacent to the site of inflammation. If you see, this is the other side of the wall, normal thickness of one of the ileal loops, while the reactive inflamed wall is thickened with increased enhancement, contrast uptake. So what do we do? What is the management in these sort of cases? Okay, initial management is non-operative. Okay, so we are going to give a course of antibiotics, IV antibiotics, reduce the inflammation, and review probably in 6 to 8 weeks and see, monitor by labs and see if the inflammatory markers are coming down, and if it isn't, and if it is going on worsening and there are more abdominal symptoms, then we would go for a rescue appendectomy, where we would go in and try to clear off the inflammation and remove the appendix. If the inflammatory markers are progressively increasing and the patient is showing symptoms of an abscess, and we need, any abscess in the body has to be drained. So a guided procedure can be done, either CT guided or ultrasound guided, depending on the available access route, and try to drain the fluid. And usually in these settings, the inflammation, usually in most of the cases, 80% of the cases, they do tend to subside after the initial non-operative management, and probably the patient does not need an appendectomy unless it again recurs. Or, of course, if you want, you can go in for an interval appendectomy. But most of the cases, it is best not to intervene surgically at this point, because if you go in right now and try to do an appendectomy and come out, there is high chance of fistulation, enterocutaneous, enteroenteric fistulations, all that can happen and hamper the quality of life of the patient thereon. So we are better off documenting what is the level of complication due to an inflamed appendix, and letting the physician manage appropriately. All right, so this is a case of an inflamed appendix that has ballooned up, ruptured, and has been contained by the body as an inflammatory focus. We reviewed this after 6 to 8 weeks, and if it has completely subsided, we just be on follow up, or the patient can go in for an interval laparoscopic appendectomy.